Hello, everyone. Hope I am audible. Please write down in a chat if it is all okay. So if I am audible, please. Am I audible? Okay, fine. So just good evening from India. Actually, we are telecasting from India. So uh, as we have previously communicated, we will discuss the first 10 cases of this session of FRCPath, that is autumn 2015. So the cases are quite straightforward, and few of the cases are needs a few discussion. So we proceed accordingly and discuss accordingly. So the case number one that was given, 27-year male patient who had a pigmented lesion in the left side of the neck, and excision skin lesions was given. So now we have the excision specimen over here, and as we can see, this skin show. So a circumscribed and symmetrical lesion, which is at the center of the skin ellipse. And if we go on the higher magnification, we can see there is a proliferation of the junctional melanocytes, and they are forming up bundles, and they're connecting from one reti to another reti. And the neomelanocytes are mostly spindle in nature. There is a significant amount of pigment in it. There is a lateral separation artifact from each other, and at few foci we can see some eosinophilic globi. Mm, so that was there in few of the foci. So the Kaminawadi was there. I have seen previously the cases that there was there. So anyway, this is a quite symmetrical lesion. So this signifies a nevus. So with the clinical history that the patient is young adult and mainly affecting the upper trunk, and is quite circumscribed. There is no mitotic activity. There is no deep mitosis present at least. So this is a variant of speech nevus, and the pigmented variant of speech nevus is known as reed nevus. So that should be your diagnosis, and you should say that the lesion has been completely excised. So and that lesion is not seen at the margin, and you can say the morphologically it is diagnostic, but you can do some markers just to say that it is all okay, that HMB 45 and HMB45 and melanate to prove it is a melanocytic lesion and overall smooth gradient of the lesion, and P16 is retained. And you say that the speech nevus can be seen in young age group, and typically it affects the extremities, upper trunk, and once it is excised, there should not be any chance of recurrence. And the patient can be relieved from any further follow-up. So this is how you complete the diagnosis and additional remarks so that you can gain some additional marks. So this is a read variant of speech nevi. Okay. Now moving on to our case number 2, that was a female 62-year, that is a postmenopausal age group, and he has a postmenopausal bleeding and endometrial biopsy was done. So what we can see, there is a 3 fragment of endometrial biopsy, and there are very good chunk of tissue we have, and few of the scanner view, you can see some glandular differentiation, mostly in a forming a papillary slit-like glandular pattern. And if we go on the higher magnification, we can see their nuclei are quite high grade, and there are quite areas of mitosis, apoptosis, all are there. So this is a high grade epithelial malignancy, as well as we can see some areas which are looking bit different. We can go on the higher magnification, that there's a kind of more plasmacytoid, or you can say that they're more of rhabdoid kind of nature. We can see this kind of cytoplasmic inclusion over here. See, this is the more of cytoplasmic inclusion. So the lesion have both biphasic. You should say the endometrial biopsy show the biphasic tumor, both the epithelial element in a glandular and papillary pattern, and there the lining is high grade, and the stromal element are showing a kind of rhabdomyosarcomatous element. So this is example of carcinosarcoma. And you should avoid the terminology of malignant mixed Mullerian tumor, because now the terminology has been oscillate from the WHO. And you can say that they are mainly seen in postmenopausal age group. You can take a help of certain marker to prove that whether the epithelial element are endometrioid or serous. You can take the help of WT1, P16, PAX8, all these kind of ERPR, and you can identify the Desmin positivity and Desmond positivity in the rhabdomyosarcoma and myogenin to prove that it is a rhabdomyosarcoma cases. And you can say that this is the heterologous element. And once the heterologous element is present, this carries a bit poorer prognosis than other nondescript stromal element. So this is a case of carcinosarcoma. You say that prognosis is mainly dependent on the stage, and the radiological assessment and gynae MDT should be done, and accordingly it should be managed. And you say that I will do obviously the P53 to show that all and none pattern for the serous carcinoma part. So this is how you build on your answer, do some prognostic comment, and the gynae MDT referral. So this is how you build on your answer script and complete the answer. Okay. Now moving on to our case number 3. So case number 3 is a 33-year female patient who have a palpable mass in the left breast. Now the needle biopsy has been given. So we can see there are 2 core of breast specimen which are of good volume. So on the low magnification, we can see some ductular lining over here and some stromal element. So you can give like you can assume that it is a kind of fibroepithelial lesion. So now we need to go in higher magnification. So there is the epithelial lining is quite monomorphic. There is no kind of hyperplasia in this. The myopithelial lining is seen. So these are all okay. There is no dysplasia or atypia in the epithelial lining. Whereas the stromal fragment, you can see that there is mitosis over here. As you can see over there are few mitosis seen scattered over here and there. Okay. And you say that the stroma is seen to occupy at least one low power field over here. So this gives the impression of stromal overgrowth, even though you are not getting some kind of atypia per se. But you suggest that there is evidence of stromal overgrowth. There is areas of hypercellularity over here. Yes, you can say. So this gives you a clue that it is a kind of atypical biopsy. You should code it in a B category, at least B3, so that they can be followed up with excision. And you can say that possibility can be both. It can be fibroadenoma with cellular fibroadenoma, or it can be phyllodes. If it is a phyllodes, it tend to be at least borderline category. You should not suggests that I am favoring a benign pillows at least in this section. So it is a atypical fibroepithelial lesion. So this terminology you can use in your diagnosis. If and you should also code it with B3 to pass the session. And you can say that I will correlate with the radiology how big the mass is, whether there is any kind of microcalcification or any irregular border, particularly because fibroadenoma tend to have smooth outline and it gives a posterior acoustic shadow, which should gives a clue towards the fibroadenoma. So radiological correlation and breast MDT discussion and the provision that yes, it can be a borderline pylorus and that should be managed accordingly by the breast surgical team, and say that the final diagnosis to be made in the excision specimen. So this is how you say that any B3 category, they take some aggressive approach, and you say that the staging in the final excision specimen will determine the prognosis, and this is how you complete the answer, and you gain the pass mark uh, for the station. Okay, now moving on to case 4. Case 4 is a female 17-year patient who have a clinically, they were suspecting of pilar cyst in the mid-back region, and the lesion was excised. So this was a lesion which was from the lower magnification. It is quite well circumscribed. I'm going to the full screen mode now. So this is a quite well circumscribed lesion, and the peripheral part is having a adipocytic component, all that, and this is the dermal connective tissue. So there is kind of pseudo capsule formation, and if you go on the higher from the lower magnification also, you can see some temporal heterogeneity in the lesion. So these are the more cellular area, and these are the area which are more hypocellular, and you can see there are some tissue tearing artifact. So these are the area where you can see this kind of hypocellular as well as cystic areas. So these were pointing towards a specific entity. And if you go on the higher magnification, you see some mitotic figures scattered over and there, but all are basically typical mitosis. Okay. Now, at the spindle, it is a spindle cell lesion. They are kind of showing some kind of fibroblastic or fibrohistiocytic character. Okay, with mitosis, and what we know that is a tissue culture like appearance, or is can be seen, and this kind of myxoid or tissue tearing artifact can be seen. And you can see that the inflammatory infiltrate is scattered, like these are the intralesional lymphocytes, and also there is interlesional erythrocyte that is known as erythrocyte extravasation. There is no proliferation of blood vascular element. The vessels are all okay, and the lesion is quite circumscribed. So this is the kind of benign fibrohistiocytic lesion with the morphology quite suggestive of nodular fasciitis. So nodular fasciitis, you say that it is a benign lesion, and you can take a help of few ISC markers, though even though they are not very kind of specific, you can expect SMA positivity and uh, Caldesman positivity in few of the cases, and it should be negative for you can say that specific smooth muscle marker. Okay, H caldesman smooth muscle marker will be negative. Okay, so this is a well circumscribed and the lesion has been completely excised, and it should not recur. And you say that in a additional remarks, and you can say that this kind of lesion is genetically having MYH9 and USP6 translocation. Even though the USP6 translocation can have multiple partners, but USP6 translocation can be seen in other lesions like cranial fasciitis, as well as also in aneurysmal bone cyst. So this kind of remarks will give you additional brownie points, as well as you say that once it is excised, there should not be any chance of recurrence. And sometimes the patient can give a correlate with the history of preceding trauma. Okay, and this is actually excision is curative. So this is a answer you should give in your exam and pass the session and gain some additional brownie points. Okay, now moving on to case 5. So case 5 is actually a elderly female, 83-year female patient with a surgical excision of 21 millimeter diameter breast lump. So if we go to the case, it show a kind of infiltrative mass from the low magnification. We can see that say, this lesion is going into the perilesional adipocytic element. It is infiltrating, and the lesion is kind of tubular to cribriform appearance. Okay, and the stroma is kind of sclerotic over here, and it's showing some myxoid changes, and it gives a very kind of you can say it resembles a tumor that is more common in salivary gland. So if you go on the higher magnification, you can appreciate there are two kind of cell, the luminal type of cell, which are more kind of having cuboidal appearance, and the peripheral myopathial cells, which is having a clear cytoplasm. And you can say there are kind of typical mitosis going on over here and there. So these are the area where cribriforming appearance is seen. These are quite cookie cutter appearance is going on. This is area which is completely made up of myopathial cells. So this is a adenoid cystic carcinoma of breast. So you should give a proper diagnosis, or if you are thinking of something like you give a differential, then don't give a benign differential, because it is infiltrating into the peri-lesional adipose tissue. So you can say some tubular carcinoma, you can say, but I will not recommend it particularly for this case, because you should give a confident diagnosis of adenoid cystic carcinoma, and you do some markers like CD117 that will typically be positive in the luminal cells, that should be negative in the myopathial cells, S100 and SOX10 to highlight the myopathial character, all that. And this kind of tumor is triple negative. So you say that I will do a hormone receptor and HER2, and I expect a triple negative status. But even though it is it is not that bad of other triple negative of ductal origin, because many a tumor like secretory carcinoma, this adenoid cystic carcinoma, they all are triple negative, but they are kind of specialized type of tumor. So once it is excised, so the staging is T2, because it is 21 millimeter of diameter. So it is almost a T2 case. But even though it is triple negative, it should not affect very much to the prognosis of the patient. And you discuss this case in the MDT, and on the MDT discussion, you can say that this kind of lesion is known to have a characteristic genetic translocation, that is MEB-NFIB translocation, and you can do it after clinical clinician request it, even though it is not very diagnostic or diagnostically required. Thing. And you can say that this kind of tumor is known to have a good prognosis. So the prognostic comment is done. So this is how you gain some cherry points, and you you pass the session. Okay, now moving on to our sixth case, at the 65-year female patient with a vulval lesion. It was 20 mm in diameter. The punch biopsy was taken. So in this case, we get a good amount of tissue. The punch is having a good amount of tissue underlying. So this is mainly a dermal as well as the subcutaneous area is affected. So if you go to our epidermal component, we see that there is proliferation, there is hyperplastic appearance, and at few point you can see there is some pseudocarcinomatous appearance, but I don't see any mitosis per se. Okay, The reason being the underlying lesion is quite monomorphic and it is kind of infiltrative in nature. They infiltrate and composed a very monotonous population of large to polygonal cells with centrally placed nuclei and very characteristic granular cytoplasm. So this is a quite characteristic for granular cell tumor, and you say that this is a granular cell tumor of vulva. Now you in the additional workup section you write that I will do a S100 stain and I expect S100 to be positive in this particular case, and I will do a PAS staining to highlight this cytoplasmic granule. So whenever possible, you do some special staining and you show your knowledge that special stain are quite helpful in diagnosis this kind of lesion, and you will be rewarded. Okay, and you say that there is also a pseudo epitheliomatous hyperplasia which is known to happen in setting of a granular cell tumor. I don't see any feature of mitosis or any spindling or any necrosis, atypia. So they are the area, they are the feature of more aggressive behavior. And the lesion is kind of reaching towards the surface, even though I am not seeing the ink here. And it is infiltrating up to the subcutis at certain points. So this is remarks you should say, and the other I see if you can say that will give you other brownie points, and also say that granular cell tumor is a benign neuroectodermal origin, and various syndromes are associated like Nuna and Leopard syndrome can be associated, and sometimes ATP gene mutation can be seen, and the feature of malignancy is like this is that I have already discussed. And once excised completely, it should not have a recurrence per se. And even though it is minutely residual, that should not do any problem for the patient. And it is not a neoplasia. You should say that it is a pseudo epitheliomatous hyperplasia, and it is known to happen with any granular cell tumor of any site. Okay. So granular cell tumor is one of the exam favorite, and you can expect in unusual location. It is a usual tumor in unusual location. So be open with it, and you also need to comment with the pseudoepidermal hyperplasia like that. Okay. Okay. Now moving on to case 7. That was a female 49-year patient having a asymmetric swelling in the thyroid gland. And the cytology was given Thi3F, and this is kind of malignant category in the NHS system. So 3Thi-F is kind of Bethesda correlate with the Bethesda 4. So be aware of that. And the patient underwent a right hemithyroidectomy. So what we see in the section, we see a section from the hemithyroidectomy specimen that show kind of nodular appearance. Okay, and from the low power view, you see a lot of bluish area which corresponds to the germinal center formation. If you go on a higher magnification, you see that the thyroid parenchyma is divided by thick fibrous tissue into lobules, and you say that this kind of cellular change is seen, and there is destruction of the follicular epithelium cells, there is presence of plasma cells, lymphocytes, and this kind of very characteristic oncocytic change is seen in this lesion. So this is a feature of lymphocytic or Hashimoto-thyroiditis. Uh, and you say that there is nothing to say about that is at this speech at this section. I don't see any feature of any follicular lesion. So I don't see any feature of papillary nuclear carcinoma, papillary thyroid carcinoma, nor I see any feature of follicular carcinoma per se, follicular tumor. And this is a giant cell. So these are the all common characteristic of Hashimoto thyroiditis. You can name it anything, but the thing is that it is benign. And the thing you should mention in your answer that once the lesion has been given a try 3F category, you should mention that I will take up the slide, I will do a cytology audit, and try to see where the lapse has happened, I will communicate with the reporting pathologist in the setting, and the case to be discussed in the thyroid or endocrine MDT, and they can manage the case further. And the thing is that patient should be assessed with the serum markers. The patient should have a raised anti TSH or anti TG or anti TPO marker, and the serum titer that actually correlates with the disease activity, because you know that Hashimoto can have a very active stage, hyper functioning stage, and a well established stage, and very fibrotic or burnt out stage. So the titer actually correlate with that disease state, and the patient should be in a follow up, because once the patient has been detected Hashimoto-thyroiditis, the patient becomes a risk for developing neoplastic change, like patient can have a papillary carcinoma or a marginal zone lymphoma, multoma. So that kind of comment you should add in your answer, and you say that the further follow-ups to be decided on the endocrinology MDT and the cytology audit you will be doing. So this kind of answer you will give, and you will get some brownie points. Okay. Okay, now moving on to case 8. Case 8 is a quite elderly female patient of 81 years, and she has a mass lesion in the left breast, and the malignancy it has been suggested in ultrasound. So once malignancy is suggested, you can get like question like this, or they can say it is U5 or R5 kind of thing to denote the ultrasonographic or radiologic finding that is the highest category possible. So in this particular case, what we see, there are three linear code of good adequate volume. And if you see from the scanning magnification, this lesion is quite hemorrhagic. We can see scattered foci of hemorrhagic intralesionally as well as in the perilesional areas. Now, if you go on the higher magnification, what we see, the lesion is quite monomorphic, composed of cells. They are quite monomorphic in diffuse sheets, or you can say some interconnecting islands, and the cells are kind of having very monotonous, as I discussed, and they have a quite a voluminous cytoplasm which gives a lesion eosinophilic appearance or pink kind of appearance. Okay, and individual cell, if you go on the higher magnification, it imparts a plasmacytoid appearance like this. Okay, so eccentrically placed nuclei, very monomorphic, as well as the plasmacytoid appearance. So the thing is that, look, this is the area of quite plasmacytoid loop. Okay, so you need to be confident that yes, what should be our different, how should I approach this case? So you obviously in this case you keep a differential of plasmacytic carcinoma, like lobular can have a plasmacytic variant, number one, but the nuclei is not that kind of hyperchromatic, or if you can say it is not very atypical. Okay, so obviously you should rule out the possibility of lobular carcinoma because cells are dispersed even though, and they are showing plasmacytoid appearance, and obviously you should rule out a possibility of plasmacytoma or plasmacytic lymphoma. Okay, so these are the three differential you should put, and the workup should be accordingly. You can choose a marker between a pan cytokeratin, CD20, and CD138. Okay, so 38 and 138. So in case of lobular carcinoma, you say that it will be coming positive for CK, and in additional, you will do, if that come positive, positive, you will confirm it with E-cadherin loss and cytoplasmic P120, as well as if you thinking of favoring plasmacytoma per se, because the patient is elderly, you say that CD38 138 will be positive, and there should be a restriction in the kappa lambda chain. You will do either, you expect a kappa or lambda chain restriction, or in case of any plasmacytic lymphoma like marginal zone and all that, that can show some plasmacytoid appearance. That plasmacytic marker can be patchily distributed, but CD20 will be diffusely positive, whereas CD20 will be negative for plasmacytoma. So this is how you approach this case. These are the three differential, and if you favor plasmacytoma, that will be the passing thing in this, and you work up this case with serum markers like albumin globulin alteration. You'd ask the physician to consult for serum electrophoresis, because M protein will be elevated once it is a plasmacytoma and it is of secretory type. And you should do a relevant workup for multiple myeloma, and you should correlate with the clinical blood picture also. So these are the usual workup you say, and in remarks you say this is a plasmacytoma in the breast is quite rare, and it can be seen isolatedly in the breast, or it can be seen as a spectrum of multiple myeloma per se. So, so this kind of correlation and disease staging is important. They do cytogenetic workup for this. Once it is a proven of multiple myeloma, that is actually more more prognostically relevant, and this kind of remarks and prognostic comment will be rewarded, and you will get additional brownie points. Okay, so this is a kind of differential case. In each session of an exam, you expect this one or two kind of differential case where you can't put your answer in particular category. You be the advice is you don't be dogmatic in any approach. You say that this can be this and further confirm by this. So lineage marker and further confirmation marker is needed, and you can ask that this can be discussed with some departmental colleague to have some coordination. This will show some kind of safe approach. So this will be appreciated in our exam scoring system. Okay. And once it is diagnosed as plasmacytoma, that can be the case can be taken up by hematology team, and further management can be done in HMDS, that is hematology oncology referral centers, and that can be managed there, and the further management they can be referred back to the district general hospital. So this kind of knowledge you can share in your exam. Okay, now moving on to case 9, that is a female 41-year patient having having a history of left parotid swelling. A surgical resection has been given from the left parotid. I'm making yeah. So from the scanner view, you have a lymph node over here. Okay, and you say that the lymph node showing a regenerative hyperplasia or reactive lymphoid hyperplasia. I don't see anything granuloma or something over here. And in the parotid, you say there is a lesion which is completely excised, and the lesion is composed of two kind of cell population. One is having this kind of squamoid cells, and other are having a mucinous character. Okay, I was seeing the case. Yes, these are the mucinous cells, and there are some intermediate cells. Okay, like that. So there are three kind of cell population, and the overall these have more a cystic appearance, and this is rimmed by your lymphocytic response towards the tumor. Okay, so this is a kind of low grade tumor. Okay, but the thing is that the grading is based on there are two kind of grading. One is your FIP and another is a Bradwin grading. So FIP is more conventional and more easy to remember, because I used to remember like IP FIP, that is your perineural invasion, the atypia, then necrosis, mitosis more than 4/10 hyperfilled, any area of anaplasia. So once they are variably actually Um, also the intracystic component, if it is more than 25%. So this there are two actually points that has been given 2 marks. 2 point for two characteristic has been given 3 marks, and one characteristic, that is anaplasia, has been given for 4 marks. So total scoring is given, and up sum total of the scoring, you can say that this is a kind of a low grade tumor, because I don't see any perineural invasion, I don't see any uh, mitosis more than 10. It is not anaplastic lesion. Yes, the cystic component is bit low, but yes, it is a low grade tumor. There is no perineural invasion per se. So this kind of grading you should do in case of in case of mucoepidermal carcinoma. And in a workup, you say that you should take further section to appropriately stage the tumor, because a parotid tumor is staged almost on the size basis that it is less than 2 or 2 to 4, more than 4, and if it is there is extra capsular extension like that. So further sectioning need to be done, further area to be looked for any high grade area, number two, and further TNM staging and further data set reporting to be done. Okay, so these are the further workup. You don't need to say that I will do any ISC marker and all that, because that is not very confirmatory. Yes, you can suggest that you can do a PAS staining to highlight the mucin. Okay, that much. And in the remarks, you say that the after complete staging, the stage is most important, and I will look for the nodal staging also. So the stage is the most important prognostic parameter, and you will discuss this case in a head neck MDT. And if they require like to document a well established genetic translocation, that is CRTC mammal 1 or mammal 3. So they can do it, and they can request the pathology department or the molecular, and you can proceed the block to the molecular lab. And you say that low grade mucoepidermal carcinoma has a very good prognosis, and it is one of the most common malignancy that is occurring in the parotid gland. And this kind of remark will give you further brownie points. Okay. Okay. So now case number 10. Case number 10 is male 19-year patient who have a right orchidectomy and for the testicular lesion. Okay. So now what you have. Okay. So now what you have in this case, particularly, you have a lesion, and that has been uh, quite circumscribed. There is no epididymis or any hilar tissue here. You don't see any seminiferous tubule over here, and the tumor is quite characteristic here. And you can see some kind of edematous and plexiform appearance. You see some glandular and cystic areas. Okay, and if you go on the higher magnification, you see that this kind of very tubular to solid to glandular appearance, and in few areas you have some papillary reticular pattern. This kind of reticular pattern is there, and you have few papillary areas are also there. Yeah. So these are the very this is kind of repetitive pattern. Again, we see this kind of lexiform pattern, some glandular pattern. The cells are not very high grade. Okay, they're having a moderate degree of pleomorphism. It is not very high grade that we expect in yolk sac or any any seminoma case. Okay, and yeah, this kind of repetitive pattern we see. And we don't see any lymphovascular invasion per se. We don't see any seminiferous tubule to comment on the GCINS or there or not. And yeah, there is no some heterogeneous area we can see. So there is no lymphocytic infiltrate, septal lymphocytosis, all that is characteristic of seminoma. We don't see any very high grade area, cell overlapping on each other. So the area of embryonal carcinoma is ruled out. So this is a pure kind of yolk sac tumor. So this pattern is quite reminiscent of yolk sac tumor. These are the papillary areas. Okay. And yeah, these are the papillary areas. So the thing is that you say that it is a germ cell tumor of the testis, and you favor yolk sac tumor particularly for this case. And even though if you are kind of suspecting some other areas like yolk sac combined or something, you should rationalize it, because once it is additional yolk sac, sorry, additional embryonal, that gives poorer prognosis, because embryonal is known to have a high grade and high grade prognosis, and prognostically it is bad. So you say in a workup, number one, you should take other sections to rule out any other mixed germ cell component. Number two, you will correlate with the serum AFP marker and expect that the serum AFP will be elevated. Number three, ISC. Number three, ISC, that it is known to positive for Glypican-3, okay, and AFP. So these two marker is known to be positive, and the broad spectrum markers like SAL4 and all that, that is a germ cell marker, is expected to be positive. And once that has been done, you will do further staging and all that parameter, because you need to measure the tumor size, you need to look for the other hilar tissue involvement to upstage it, to you look for the that seminal cord resection margin and all that. So this is a very important workup you need to do. And you say that the case will be discussed in a urological MDT for further management, because the what is the status of the lymph node, peripheral lymph node and all that, that can be discussed in the urology MDT. So this is how you complete your answer, and this kind of workup is needed to be there in your answer to gain additional remarks. Okay. And in case of once it is proven to be a germ cell tumor, it is to be referred to a germ cell referral centers in UK. Okay. So this is standard practice in NHS. And biochemical invasion. And okay, now one important thing is that in testicular tumor, the staging is TNM A staging. The A staging depends on the additional, apart from the AP, that depend on the LDH, that depend on the beta HCG, as well as albumin, if I'm not wrong. Let's take it. So I need to check, please all check with the other staging. So three parameters are there. So that determines the okay, so this is LDH, HCG, and AFP. So these are the three marker that is given, that is needed for TNM A staging. That is important, and if you say that, that will give you a good impression to the clinician. Okay. Okay, so this is to the case 10 as we have discussed. And any question, or yeah, we'll discuss rest of the cases in the next session. And any question, Dr. Supasakti? Actually, yeah, cellular fibroadenoma and borderline phyllodes can be a differential. You can put a differential in a TrueCut biopsy, and both actually comes in a B3 category. Okay. And actually, if you say that borderline phyllodes, you will do further actually categorization to the lesion in the excision, that is well good enough. But the thing is that it is atypical cellular fibroepithelial lesion. Yeah. And also you can ask for the consultation with the breast colleague that will help to actually determine the type of tumor. Okay. Your next question is how to differentiate adenoid cystic carcinoma from invasive cribriform carcinoma of breast. Okay. So one thing is that the invasive cribriform carcinoma will not have the dual cell lining. Okay, the cell lining will be CD1 117 positive in case of adenoid cystic carcinoma. Okay, and yeah, that the adenoid cystic carcinoma will be ERPR negative. Okay, so this is how you will. Okay, your next question is how can we talk about IgG4 related disease in Hashimoto thyroiditis? As I can see fibrosis and plasma cell infiltrate. Okay, now the thing is that IgG4 related disease will have much kind of storiform fibrosis, which is not there. There should be obliterative phlebitis also. So once there is, look, the plasma, whenever there is a plasma cell, it is actually a fibrogenic because IL-6 that is kind of related with the pathogenesis of any plasma cell related lesion, they induce a fibrosis in the additional tissue. So don't go by any amount of fibrous tissue in the lesion. So once you see that storiform fibrosis, kind of very organizing fibrosis, because see, IG4 related disease will be more of stroma rich than the cellular rich. Here we get more kind of more kind of cells. The cells like Hashimoto cells and plasma cells are there. Even though you are suspecting a IgG4 related disease at a very initial stage, you should say that I can discuss this case in the clinical pathological correlation to do a serum IgG4 marker or IgG serum estimation. If that is elevated, and there is radiological evidence of any multi-system involvement like the parotid, like the retroperitoneal involvement or the pancreatic involvement, this kind of multi-system involvement with a specific clinico-pathological setup, because IgE4 is not a your histological diagnosis per se. So there should be a serological confirmation, there should be a radiological confirmation, and also a clinical suspicion. So this is how you can put a differential, but I suggest that IgG4 should not be commented particularly for Hashimoto. Okay, so this can show some kind of lack of confidence in this particular case. Okay, so if there is any further question, we can take up or we can log off this session. We'll meet next week for rest of the case discussion. And thank you all for engaging. And you subscribe to our YouTube channel so that you can get notification for any live or any video we upload in our YouTube channel. Okay. Yeah, it's